this year's first Pan India ILD MDM. It's truly exciting to begin the year with this discussion forum, especially when we are expecting more experts to join us in this year in the form of pathologists and maybe pulmonologist experts also. We will welcome our international expert, Professor Athol Wells and Professor Sonia. And nevertheless, there are equally uh, intelligent and knowledgeable uh, experts from India also in the form of Rajan sir, Murli Mohan sir, and Prabhu Desai sir. Today's our radiologist expert is Major Vimal Raj sir. Thank you so much, sir, for joining. And Dr. Sharda is our pathologist expert. Dr. Mithun is my colleague, and he is our rheumatologist expert. Presenters, one case is from my side. The case is presented by Dr. Marin, but the case was actually jointly managed by Dr. Lisha and Dr. Anthony from Amla Hospital, and they also will be on this call, and we welcome them. Dr. Nishant Sinha is my colleague from CMC Vellore, presently working in Hyderabad. AGP Hospital, and he is going to present the case number 2. Case 3 and 4 belongs to my colleague Dr. Shobha Madam. So I'll start sharing my screen, and Marine will be presenting on my behalf. One second. Yeah, Marine.
Good evening, everyone. So this case was discussed in the MDM that we conducted on 12th December. This is a case of a 28-year-old female from Kerala. She's a teacher who presented to us with progressive shortness of breath and dry cough for 1 year, and her symptoms had exacerbated post her delivery. She has exposure to birds 2 years back at home. Her vitals at rest were stable. She had grade 3 clubbing and bilateral basal crepitations on auscultation. Her blood workup, total counts were elevated. Her serum Ig was high, more than 1,000. HP panel was positive for Aspergillus fumigatus, Cladosporium, and Penicillium. Her BAL analysis showed 35% eosinophils, 23% neutrophils. Rest of the workup is all negative. Her PFT showed a severe restriction with significant desaturation in her 6-minute walk test, up to 75%.
Yeah.
Her ANA profile was positive for AMA M2+. And myositis MI2 alpha was positive. PL12 is also mildly positive.
With that, I will stop sharing. And by the time, if Mithun, you are there, can you please comment on those report? I believe you did last time also, but just for the sake of audience who joined today. 1 second, huh? Just have you seen this report, Mithun? You're there? Not sure. Okay, you go ahead, sir.
Just 1 second.
Yeah.
There was a Me Too that was 2+, right, Asmita?
Yes, sir.
Yeah. 1+ or 2+, was it, Marin?
It's a 2+.
2+.
So this is the CT scan. So we have got 2 CT scans. So this CT scan is from initial presentation, which is from the 5th of August 2025. So you can see this is what the chest radiograph looks like. We'll just quickly go through the mediastinal window. What we are seeing on the mediastinal window at that point in time is that there are small volume, there are few prominent lymph nodes in here. Again, small volume lymph nodes. in the mediastinum, very trivial pericardial fluid, nothing much in the upper abdomen. And at that point in time, if you see the pulmonary artery was also within normal limits. You just quickly show you the lung windows. I think better to go in. So this is the lung windows from August. And when we see here, what you will see even at the top, you're starting to see some of these black holes in the lung parenchyma and diffusely nodular appearance that we can see. There is some fissural nodularity all along that we are seeing, and peribronchial nodular changes extensively seen in the lungs bilaterally. Upper, lower lobes all are involved. There's some ground glass opacities all along, bronchocentric distribution, not much in terms of tractional dilatation of bronchi, but predominantly what we are seeing is nodules with a lot of ground glass. Now, when we look at the expiratory film at that point in time, this is again, we are looking still in August. It's not much in terms of air trapping that we can see. The esophagus also looks to be within normal limits. So, in summary, we are seeing a youngish patient who's got some form of emphysematous changes and then a lot of nodular changes. First and foremost, I would have thought of sarcoid as a differential diagnosis in here to be considered with this. The amount of ground glassing and the profile of the blood work, CTD would be the second thing I would consider. I do have a follow-up CT in 4 months. Do you want me to discuss that now?
Yeah.
So,
If before you discuss it, Asmita, what was the working diagnosis on 12th
so
December?
we made a diagnosis of myositis, sir.
Myositis ILD.
Yeah,
Okay.
because the myositis ILD, because she was very young and she was so sick that time, and she received all kind of immunosuppressant. And before we go to anything, why did you say, Vimal Raj sir, that there is emphysema? Where is that emphysema actually?
So when you're looking at these holes in there, whether you call them cysts, they
So,
are
sir,
not.
last time we discussed that it is a single layer of honeycombing. That is what we discussed, sir.
So single layer of honeycombing, I wouldn't like it in the central areas here. If you see
Okay.
across here,
Can
these
it
are
be
quite
cyst?
central.
Because if I'm thinking of some cystic lung disease or something like that.
These are actually isolated to the upper lobes. We are not seeing them in other parts of the lung. So maybe one area across here. These can be called cysts, but not a cystic lung disease.
Okay.
So where did we end last time, Asmita? What was the final plan?
So discussion was, I think Disha is also there. So discussion was, infiltrative lung disease is a possibility, and we should do a PET CT. because
Mm.
because we should not miss something like that, because here the problem was the pregnancy aggravated the existing problem. That is what we thought, because
Sure.
we didn't accept that it was not there before. However, everything started worsening after pregnancy. So all immunological condition, I think Professor Athol Wells and Sonia both were there, and they agreed that it can be myositis related, but it has to be leaked further. And one possibility which Bhavin sir suggested is we should do PET CT to rule out uh, lymphoma. Yeah.
I think
Lymphoma.
the last time, if you were saying the MDT was on 3rd of December, did you have this other CT also at that time?
PET CT was not there, sir.
No, this is another CT of 3rd of December. What
That
I've
was,
showed is in
yeah.
August 2025.
So that was post treatment. Yeah, sir, it must be there.
So
The
then we
reason,
discussed the treatment, what the effects of the treatment were, Asmita, on the 12th of December.
There was no much change. That's what sir told. Yeah.
so the only reason I
Okay.
say this is that I'm just showing you now the CT, which is from the 3rd of December. The lymph nodes were more impressive in 3rd of December. And maybe that's why Dr.
Bigger.
Bhavin would have said that, you need to exclude lymphoma as a possibility. Because if you see by this time, this subcarinal lymph node is much bigger,
Yes,
much
sir.
more distinct at that point in time. The lung parenchymal changes were again very similar, if at all anything slightly more worse that we were seeing. So a lot of nodularity in the fissures, more nodular disease with focal areas of at the top as we were seeing those cystic changes in that.
So you mean to say the lymph nodes have significantly increased in size, right?
One of the lymph nodes had significantly increased in size between August and 2012 December, 2025.
Which is probably why Bhavin wanted a PET.
Correct.
I guess where to direct a biopsy, if at all, to be done, right?
Yeah, absolutely.
And so then what happened, Smita?
Yeah, so we did a PET
So
CT
how
and
how will you explain such a high level of eosinophilia and BAL?
Can't hear you,
Lymphoma is
Prahlad. Yeah, a little soft.
no. How will you explain that such a high level of eosinophilia and BAL? And second thing is that even peripheral counts are also very high. You are not we don't have eosinophil count there, but that also is high. Okay, so with the lymph nodes and such a nodular shadow in the lung, B cell type of lymphoma, I have seen such patients on biopsy.
so that point we discussed last time, sir, and I believe Lisha is there. And Lisha, if you can just give an idea of what treatment you people have already given, because I believe she received pulse steroids and she received rituximab and she was already on MMF or something by the time she came to us, right?
Yes, madam.
Yeah.
Actually, in the first August thing, she was referred for ILD evaluation. That time, this MI2 positivity came, and she had a consultation with rheumatologist who suggested a trial of pulse steroids with rituximab. And that time, they were not willing for a biopsy, so it was proceeded with pulse steroid with tapering steroids over 1 month and rituximab. She had marked symptomatic improvement, and we lost follow up to her. Once they started tapering the steroid, she came back again. She became dyspneic, and then she came back, and that is when the second discussion and referral to Amrita occurred. That is when Madam is seeing the patient. The second CT is after the pulse steroid and rituximab, and then we are with after your first MDM, we proceeded with the PET CT, and I think the PET CT images are here.
You got PET CT images,
No,
Rumiraj, or no?
I did not.
Yeah, so that I forgot to send you. But I think we have the report was not any different from the PET was negative, right, Lisa? There was nothing
The
to
PET
suggest.
was not having a significant uptake in any of the lymph nodes. There was a diffuse uptake of bone marrow, which they told as a reactive marrow. With the diffuse, no, the lung nodules were around 3.2 SUV. Diffuse uptake was there, so it was decided to go for an. If the images are there,
Yeah, we'll show you the images of lymph node.
Vimal,
No,
with high dose of steroid when she was receiving, does the pet will have she uptake?
With lymphoma, yes. But if there is something like sarcoid or something, it may have gone down in activity, but lymphoma, it will still show uptake.
It will show.
1 second. I just will send you the images. Sorry.
In this patient, BAL was done that time. Infections were also thought of, or
in
was
the first BAL, all infectious workup was
negative.
negative,
Okay.
including all the PCRs.
Okay.
I don't know. The images are not getting open here. I don't know why. Marin, if your computer, it can open, you open from there. The histopathology images.
So in this patient, if you want to do a biopsy, okay, Vimal, what is the right area? Because lymph node appears to be very easy to biopsy. Okay, and
See,
the
both the upper lobes and lower lobes, the disease is so diffuse that you probably can go anywhere. It's just that the upper lobe has got more cystic changes. So the chances of pneumothorax, etc., might be higher. So lower lobes, both are good. There is a lot of activity, inflammatory activity that we can see in both the lower lobes.
Marin, if you can open the images from your computer, can you please try? It is not opening in my system.
So you got a biopsy done, Asmita?
So Lisha did biopsy. It is some problem in my system that I'm not
Went
able.
forward with an open lung biopsy, sir. Because of the anesthesia fitness, we couldn't obtain, and the specimen was taken from the anterior segment of lower lobe because of the surgeon's convenience. And I think Madam has the images.
Yeah.
Do you want me to share?
Yeah. Yeah. Please share.
You can you share, sir? Because Marin is not listening and I'm not able to open it
No,
here.
ma'am, I'm not able to open it here.
Just
Yeah.
1 second.
So Athol, to just fill you in, this is a 28-year-old girl that we discussed on the 12th of December or 11th of December, who had breathlessness and cough for a year and got worse postpartum, if you remember that lady. And the suspicion was a myositis ILE. You and Sonia were there. And the scan had not really got better with immunomodulation. The lymph nodes had slightly increased in size. Bhavin was suspecting possibly a malignancy, and so he said to do a PET. And then they did the PET, and maybe Vimal will just briefly tell you what the PET was before the biopsy. Yeah.
I think I've not seen the PET, but basically on PET, there was no uptake in the lymph nodes. There was diffuse uptake of the marrow edema. That was the only thing which was thought to be physiological.
Yep. Yeah, Sharda, you can go ahead, please.
Yeah, so what I could see is there is focal interstitial widening is there, but this interstitial widening is not due to fibrosis. There is lymphoplasmacytic infiltrate, mononuclear inflammatory infiltrate. That is what I could see in both the images, but I couldn't appreciate much of fibrosis in these two. And yeah, so these are the closer pictures, closer views, and this is showing dense lymphoplasmacytic infiltrate.
Yeah.
But yeah, whether these are atypical lymphoid cells or whether these are just lymphocytes, I'm not able to make out in these images.
So you need IHC for that, Sharda? Or?
Sir, histologically, atypical lymphoid cells can be made. Suppose if it is a lymphoma, like a diffuse large B-cell lymphoma, and not a low-grade lymphoma, then the atypical cells, the lymphoid cells can be made out. But still, again, I mean, to classify, I will be needing immunohistochemistry even to rule out whether it is a reactive lymphoid infiltrate, because here it is showing such a dense lymphoid infiltrate. So immunohistochemistry has to be done to rule out a low-grade lymphoma like a mild lymphoma, or whether it is just a LIP, lymphoid interstitial pneumonia.
Sure.
We will, sir, can we go to previous slide, please? So, can you see emphysema here, Sharda?
There is mild emphysematous changes. It's not very gross. This is between an overinflammation of the spaces and between emphysema. It's not very drastic emphysematous changes that I could make out in these images.
Mm-hmm.
But the biopsy is from the lower lobes also, where there was not much changes that we've seen.
So
And
these all open spaces, now it's not emphysema, right? These
are
like
overinflated. No, these are overinflated air spaces. And for emphysema, it should be, it should be more, the distension of the alveolar spaces should be more. That's
okay.
what I'm trying to say. But more than emphysematous changes, this lymphoplasmacytic infiltrate is the one that is more significant here.
Okay.
I've got something like this here. Maybe
I will share from here,
Yeah,
sir.
I'll
It's
stop.
okay. Yeah, that those things are opening. Only images were not open.
So is there immunohistochemistry done in this case?
Yeah, that images I have got. I think those images were also opening. Only this thing was not opening. 1 second. So IHC was done and we have put the report also, and I send you those images also. So those images are opening here. So I'll start. So they did CD138 and IgG4 and IgG because plasmacytic infiltrate. So whether it is there or not, and then there are two more which are awaited. But she told she's not thinking of lymphoma, my pathologist, and she told she feels it is more like a CTD related. Yeah, this is the report. This is not this provisional report, but this is what it is. You can see this is IHC.
Yeah, so CD138 is positive in scattered plasma cells, and maybe because of this fibrosis, they have thought of IgG4, and IgG4 is showing it's like it's not increased.
Mm.
IgG and IgG4, and CD3 is positive, and CD maybe because they have thought of lymphoma, they have done both T cell markers and B cell markers. T cell marker CD3 is positive, CD20 there is no staining, they said. But I mean, I don't know why they have said no staining. Usually, if the CD20 is also positive, means CD3 and CD20 both are positive, it is a reactive lymphoid population. There is no B cell predominant component. So, I mean, based on this IHC, it doesn't look like a lymphoma.
Yeah.
And CTD related ILD, based on this, I don't know. I mean, how they have written, because chronic inflammation can be seen in many other conditions, even HP also, cellular
Maybe
interstitial
because of
pneumonia.
lymphocytic infiltration, the NSIP diagnosis is more likely, or what do you think,
This
Sharda?
patchy interstitial fibrosis doesn't go to I mean, doesn't go towards NSIP, because NSIP has a homogeneous interstitial fibrosis. And in this biopsy, I couldn't see any interstitial fibrosis. It is the dense lymphoplasmacytic infiltrate which I am seeing in these biopsies. So, based on this, I will go for an immunohistochemistry to rule out lymphoma. But based on the IHC that they have done, it's not looking like a lymphoma. Maybe this is a reactive lymphoid infiltrate, and maybe it's Sjogren's. Are there any clinical symptoms of Sjogren's? Because cysts and lymphoid interstitial pneumonia, focal LIP pattern is going in favor of Sjogren's.
Yeah.
Or
So
maybe
this
CTD related ILD if it's not Sjogren's.
that's true. So even Murli Mohan sir is commenting. I think Murli Mohan sir last time also said that this is like we used to high eosinophil count, but the logic was which eosinophilic lung disease will not get cleared with pulse methylprednisolone. This very unlikely. Now, what do you say?
Yeah, but you're not seeing eosinophils on the biopsy.
No,
Sorry, I
biopsy
thought.
is not showing eosinophils.
Yeah,
I
biopsy is
thought
also
I
not.
thought your audio is bad.
Yeah, I mean,
Ah,
I don't remember the CT images, and I had to clock in late for this, so I missed the first part of it. But with that proviso, I would say the key is to be
Sorry, sir. We will show you the images also because this
yeah.
case
Vimal,
needs
can you
your
pull it up?
opinion.
Yeah.
I'll just finish what I was going to say.
Yeah.
The key is to go to some lengths to exclude a lymphoma, whatever you say about likelihoods. Now, I do understand I wouldn't be necessarily thinking about lymphoma first choice here. I think the features hint at a CTD. The resistant CTD, where you feel it should respond, tends to be an inflammatory myopathy. But nonetheless, I think there's enough here that is weird that you're planning to exclude lymphoma in spite of the fact you think it's unlikely. I've been here a number of times and it does turn out to be lymphoma, even though you think it's unlikely. So that is the key step. It's the immunohistochemistry to be sure about that. Then you know it's an ILD, and I think your full armamentarium of what you would use in an inflammatory myopathy becomes appropriate, even though we're not saying this is inflammatory myopathy. But there are features here that should respond to therapy if it's not malignant. So you're then obliged to pursue responses with the range of treatments that you do use in this context. So, I mean, I don't know what this is, but I do know that I would really, really, really want to exclude an atypical lymphoma as the very next step.
So if the pathology has largely ruled that out.
Well, without the special staining, I'd be a bit careful. You know, that first observation that Sjogren's has LIP, Tom
Yeah.
Colby went back to the initial series, and they didn't publish this, unfortunately. But all they were calling LIP turned out in most cases to be atypical lymphoma in that first series, interestingly. So I think you can be fooled, and especially if you're talking about a form of Sjogren's, Sine Sjogren's, which is, I think, what you're saying from the histology. Well, the lesson there is that if you're going for LIP, just be very sure you're not dealing with a lymphoma.
Sure.
So in this IHC, actually, they haven't mentioned about CD20. CD20, no staining they have written. So
So CD20 did not take uptake. That is what she's meant to say. She spoke to me. So CD20 is almost like they did another stain because CD20 was not taking uptake. So positive or negative was not commentable. So that is why she did the other alternative stain which is awaited. That is what she has written.
Yeah, so based on that, it depends upon on that, because CD3, if they are saying, means all of them are, if the CD20 suppose if they have comes positive, then I will say that this is a reactive lymphode, because CD3 and CD20, I mean, both the T cells and B cells are there. It is going more in favor of a reactive. Suppose CD20 is staining more of these cells, then it is going towards B cell predominant, B cell lymphoma.
Okay.
And what do you see in atypical lymphomas, Sharda?
So malt lymphoma, usually the CD20 is highlights more. The cells take up more of CD20 positive cells will be there. And yeah.
And so if the lymphoma workup was negative, this was classified in the last MDD as a myositis ILD athy. So would we call this an amyopathic myositis ILD?
I think we would, and I like the label because if you're going to pick the CTD where you think you should get responses and you don't, and it's frightening, it's the myositis. So people dying with organizing pneumonia that just won't respond to whatever you give. It doesn't seem to happen in other settings. This is a case, I think, from my memory, that there's been resistance to initial treatment. Is that correct?
Yes.
No, that's right.
Yes.
So it's following a pattern, and you might expect from what you're seeing histologically that it should have responded to treatment. So it's almost a signature of the range of what we group together in inflammatory myopathy. So you've got an armamentarium here, which you probably need to empty fairly quickly. Young patient from memory.
Yeah.
And the crime is to miss an opportunity. So you're going down a rituximab pathway. You're thinking about TAC. I suppose that in another setting you might use JAK inhibition versus TAC. It's that debate, and I think it was a Chinese series which was quite large, showing if anything maybe there's an argument for JAK inhibition. I'm not sure in this case because this case is difficult to classify within the spectrum of what we do see with disease that ought to respond that doesn't respond in inflammatory myopathy. But just that signature is enough that I think for practical purposes, for management purposes, an inflammatory myopathy algorithm is appropriate for treatment.
I have one problem. So if we are suspecting malt lymphoma, that I had seen enough. First of all, the radiology is not classical of that. Second, those kind of lymphoma, the treatment of choice is maximum rituximab or steroids, both of which.
No. If you find a lymphoma, you go into a lymphoma treatment algorithm with the drugs recommended for the lymphoma and validated in past studies. So I think that you should be able, with full immunohistochemistry, to come up with a statement along the lines we've heard anyway, that you're going to say this should not be managed as lymphoma. You've done enough with further immunohistochemistry to be clear about that. If you're saying it could still be, well, you can't really manage as for a lymphoma, you can still say that this is weird, whatever it is. So it doesn't fit well with whatever we might choose to call it. But we're saying for practical purposes, either this is managed as a lymphoma or an appropriate management algorithm is as for inflammatory myopathy, with the sort of disease that ought to be responding but isn't. So you then go fairly quickly to your range of therapies that you use in this setting.
Patients which will not respond. So last time discussion was, it was ill-defined bronchocentric granulomatosis, subpleural nodularity, fissural nodularity, thickening, cystic upper lobe changes associated with PPFE because of shrinkage of apical segment. The diagnosis was NSIP, CTD, or PPFE. But because there was a homogeneous distribution, indeterminate pattern, and multiple overlapping features. And 3 months later, single large lymph node. That is exactly what Sir said. And discussion was autoimmune pattern. Very likely because a patient did not respond to 1 gram of methylprednisolone rituximab. No good response. So what to do? To do biopsy and PET-CT imaging, sarcoidosis, lymphatic system involvement, lymphoma has to be ruled out. And 1 point from Prabhu Desai sir was tropical eosinophilia. That is what we discussed, and that is where the discussion ended. Yeah.
And
Well,
another
that
thing
seems
is,
to me to have been a very fair discussion last time. The trouble with this is you don't remember a month later what you said.
No, that's why I write.
But
Yeah.
basically, that seems to have summarized the dilemma very nicely. I mean, what you call this, first of all, you're reaching a conclusion. We are that we think some form of immune dysregulation is likely to be driving this.
Yes.
So whether you call this unclassifiable or whether you call it a form of ILD driven by immune dysregulation with a management algorithm as for inflammatory myopathy appropriate, you're probably characterizing what you can reasonably call this and what you should reasonably do about it. And the only caveat is the atypical lymphoma.
Okay. So it's worth sending full lymphoma panel antibody. For cost cutting, the patient was done only 5 antibodies, which is like covering everything. One was bronchoalveolar carcinoma, which was Lisha was thinking of that, right, Lisha? And then we thought that we will rule out this IgG4 and all those things. So only 5. We can order full lymphoma
yeah,
panel of
other
antibody.
lymphoma markers have to be added in this.
Sure,
Cyclin D1, BCL2, BCL6. I mean, a full
sure.
bulk lymphoma markers have to be added. And even if they come out to be negative, it is the B cell rearrangement studies, which is the one which decides whether it is a low-grade lymphoma or whether it is just an LIP.
Yeah.
Another
And
doubt is, should I go forward with a bone marrow? Will there be any advantage? That is
and
one thing we have not done.
Professor
Peripheral smear
Wells.
was neutrophilic, mainly
I think
neutrophilic with no atypical cells. Multiple peripheral smears.
somebody needs to ask a lymphoma doctor about that.
Okay. Okay. And your
And
rheumatologist wanted to add anything, any further immunosuppression, Lisha, or you're
No,
happy
no,
with the
rheumatologist is not willing to take this case up anymore because he thinks it is not. I mean, that was
not
his
his
opinion.
case, not his
Yeah.
case. Okay, fine.
I can understand somebody very quickly saying, I don't want this to be my case, but you are going to say what you do next in terms of immunosuppression. How long ago was the rituximab given?
That was in October. That means it
That
was
means
3
that
months.
you've got
Yeah.
more than enough time to see that it hasn't responded, if that is correct. I mean, I missed your update at the start, so I'm assuming this is non-responsive still, is it?
Actually, at that time, the patient had symptomatic improvement, but I didn't see the patient at that time. She came back once they stopped rituximab, were tapering the steroids to 5 mg prednisolone. That is when she became dyspneic again, and that is when she came back and we had this reevaluation.
So there is
Right.
some comment in here that Sharda, for you specifically, that CD20, because they have specifically written it is not taken uptake. A patient received rituximab just recently. Can it make negative?
No, I think the question
I
was,
don't.
does a CD20 negative, Murli was asking, imply that rituximab won't work? I don't think it implies that, is my view, because I think rituximab works by systemic B cell depletion, not just in the lung tissue.
I agree with that. Trying to do staining to work out whether rituximab
Yeah,
would.
we have to do the full
Full
lymphoma.
workup, and
Yeah.
I don't think there is a need of a bone marrow biopsy on the same block. The entire panel of lymphoma panel can be done.
Okay, madam. Any role for genome sequencing in this block? I mean, can it be done? Is there any role? Generally, also in this case, whole genome sequencing.
B-cell rearrangement studies can be done to rule out a lymphoma. That is more specific compared to immunohistochemistry.
Okay.
We had sent telomere, Merin, for this patient. You
Yes,
muted.
ma'am.
Yeah. Telomere we have sent because that is done presently free in our hospital, and I will update you about that. We are not reaching anywhere, Lisa. We have to stop here
Yes,
because
ma'am.
it's a very difficult case, as you can see, and maybe we need to get answers over a period of time. Thank you, and
Yes, madam. Thank you. Thank you very much.
thank you. I will start sharing the screen for the second case. And yeah, Nishant, over to you.
Yeah, good evening, everybody. My name is Dr. Nishant Sinha. I worked in AIG Hospital, Hyderabad, as a consultant pulmonologist. After the last case of mind-blowing discussions, I would like to start my case. This is a story of a 36-year-old man who is from Aurangabad, Maharashtra. And I'm in Hyderabad. So this patient traveled all the way here for the proper diagnostic workup, I think 500 miles away. He's a non-smoker with the complaints of dry cough for 4 months, occasional fever spikes. He is breathless with the MRC grade of 2, which has been progressive for last 1 month. He works as mason, and which includes construction site work with cement dust exposure. He mixes mortar and he applies in the wall to make it. He has got no background comorbidities. He was quite fit and active till 4 months ago. He has no past history of pulmonary tuberculosis, bronchial asthma, or previous illnesses. He has got no exposure to birds or pets. If you see his previous workup, he has been admitted almost 3 times elsewhere in the past 4 months locally. He had 2 bronchoscopies where BAL was only done. It was all negative for everything, including cytology, bacterial, fungal, everything. But he had BAL lymphocytosis from the discharge summary you could make out, for which they prescribed him oral steroids, which he took for almost 1 month. Initially, cough was a bit better. And then on stopping it again, reoccurred, and he was more breathless later. And he came to our center for evaluation. On examination, he was tachycardic with a pulse of 110 per minute regular. He had room air stats of 84%, but with oxygen it was 97%, 4 liters. But in a day it was like on 3 liters he was requiring as the oxygen to maintain a stats of 95, 96%. Clinical examination was clear. He had no systemic features, no palpable lymph nodes, no skin rash, no other features of even CTDs or contributory disorders. Next slide. So this is lab findings. His hemoglobin was 12.7. He had peripheral eosinophilia of 12% on the first day. After 2 days, eosinophil 8%. He had initial slight transaminitis, which got better by its own. In the next 2 days, it was all normal, persistently normal. I did LDH on day 1 because I was suspecting lymphoma also, which was normal. His echo was normal. RVSV was 28. There was no right or left heart disease. Spirometry was showing severe restriction with FVC of 1.9 liters for 2%. There was no FEV1 reversibility. Next. So coming to radiology now, let's see. He had 3 CT scans, 2 prior to coming to me, and finally I did CTPA when he met me. So let's see that.
So we have 2 CT scans to show you on this 33-year-old chap. So this is the first scan, which is from October. You can see diffusely abnormal lung parenchyma. I'll start with this contrast study itself to begin with. And what we are seeing are these extensive mediastinal lymph nodes. And definitely you are seeing these dense areas of pulmonary parenchymal consolidations with air bronchograms in both the lungs. And as we go further down, these are getting even worse as we move down. A couple of things for observing within this whole thing was, so this is in August, and if you see some of these areas where I'm show you normal lung parenchymal enhancement versus this area, these are hypo enhancing areas within, so like areas of breakdown within these parenchymal changes with some air pockets going through. So multifocal areas of what looks like differential enhancement in the lungs. The other thing which is a bit unusual is the kidneys. The kidneys don't look normal. And you can see multifocal areas of abnormal enhancement in the kidneys bilaterally. When we look at the lung parenchyma at that point in time, there is very little lung parenchyma left, which is normal, to be honest. And there are extensive nodular as well as ground glass areas of consolidation with the intervening lung otherwise looks normal, but most of the lung is involved in this case. So at this point in time, I would have been thinking more in terms of an atypical infection with renal involvement. I'm thinking that there could be bilateral, both viscera being involved. In situ cancer adenocarcinoma, that's something we need to think about with organizing pneumonia pattern. But first and foremost, with that differential enhancement, I'd be thinking in terms of fungal infections. That's very common. This is the other CT of the same gentleman. Now, this is 4 months apart. This is more recent from 26th of December. We can still see these lymph nodes which are present. There was no pulmonary embolism, so septic emboli is out of the diagnosis in here. And what we are seeing is those areas which had shown some poor enhancement, they've now broken down in the right lower lobe. And the kidney parenchymal changes remain. You can see very heterogeneous appearing lesions in the kidneys also. Bilateral renal parenchymal disease also is seen. We look at the lung parenchyma now. What we are seeing are dense ground glass opacities, somewhat better from before, but there has been progression. You can see these areas of clustering, bronchocentric areas of ground glass and central halo around these opacities. So for me, atypical infection, organizing pneumonia would be the top two things that I'm looking at.
There was one more city in between. There was one city in October. Did you get to look at that?
I got only two in that.
Three, actually.
Okay.
Okay, next the slides.
Yeah.
So after the city, we went and did the bronchoscopic evaluation for the patient. So by bronchoscopy was done, BAL was done, even lung biopsy was done. So BAL was done from right middle lobe with a 120 ml in and 55 ml return. It was a clear fluid. There was no bloody return. Cell count was lymphocytes 44%, neutrophil 56%, no eosinophil. Cytology cell block showed no malignant cells. AB smear, gene expert, bacterial pathogens, all were negative. Galactonin from BAL was negative, but BAL from the middle lobe grew Aspergillus fumigatus, the day 5th. And AB culture so far is negative. From the lung tissue, AB smear, gene expert is negative. Tissue culture so far is negative. So based on this, I just put him on voriconazole. No steroids were started. I did a video consult with him 10 days after 10 days. Yesterday. His cough is still persisting. It's not better. He didn't have an oximeter, so we couldn't check saturation. He's still breathless with MRC grade of 1. And I think there's a very slight improvement. I won't say that he's really improved. So we can have the lung biopsy report now.
Yeah, so this is the biopsy which I have received from Dr. Nishant for a second opinion consult, and it is actually an excellent biopsy with 5 fragments of alveolated lung parenchyma. Along with that, the central fragment is also showing the bronchial wall. And all these fragments, this is the a closer view. All these fragments, all the 5 fragments are showing this multiple granulomas. These are all the epithelioid granulomas, and these granulomas are in random distribution, meaning they are seen in the interstitium, they are seen in the air spaces, and they are also seen in the bronchiolocentric location. And this is a closer view of one of the granulomas, and it's showing lymphocytes, plasma cells, and epithelioid cells. And apart from these granulomas, I couldn't find much of necrosis. Very focal necrosis was there. And apart from these granulomas, there are these dust-laden macrophages. These are because the patient is already exposed to dust. These are the dust-laden macrophages along with interstitial fibrosis I could find on the biopsy. So based on these, I have signed it out as a granulomatous inflammation and possibly of infectious etiology. And I have done special stains. AFP was negative, and even fungal stains, PIS and GMS was negative.
So if we summarize the problems, this is a 36-year-old gentleman who is a Mason by occupation with non-resolving pneumonia, which is peripheral lung distribution pattern. That's what I understand. There's a blood eosinophilia, but there are necrotizing granulomas on lung biopsy, and he's got native autoimmune workup. So are we dealing with only infective process, or is there any organizing pneumonia also along with that? Previous balls and current lung tissue completely rules out tuberculosis. So can you agree on a diagnosis and treatment plan? He's just on
Hey,
voriconazole now.
this particular pigment, na, Sharda, is it anthrochromatic pigment
Yes,
which
this is
we...
anthracotic.
Okay, that is what it is. And then can it be something related to silicosis kind of granuloma?
Oh, yeah, can be an anthracosilica. I haven't polarized this. If I could find some few silica particles in this, then I would have called it as an anthracosilicosis. But
Can we do that yet? मतलब अभी भी कर सकते हो क्या आप?
yeah, it's like it has the polarizer should be there
Okay,
to polarize it. So I mean, like even this can be a predisposed. I mean, this mycobacterial infections can be seen in this silicosis, and in fact, more in silicotic patients when compared to an anthracosis patient.
Do we still think of mycobacterial tuberculosis? Repeated samplings has been negative, and lung tissue is negative so far. Previous ball cultures are negative. So how do you entertain that tuberculosis diagnosis? I just want to know that.
Nishant, what's happened in the 4 months between the two scans?
So I'll tell you. So he was admitted in a medical college hospital there. So first bronchial lavage was done, and he got broad spectrum antibiotics. He got, I think, Piptaz, doxycycline, and he was marginally better. Discharge again came back. This time they did again lavage. There was one report of some flow cytometry from the ball. I'm quite surprised. What is that? So, but they concluded it's a lymphocytic ball. So they started steroids, 40 milligram OD, and they tapered to around 10 milligram in a month, which patient stopped himself. And then he symptoms worsened, and then he came to us. So that's the story of treatment. So basically, treatment was he got broad spectrum antibiotics plus steroids, nothing else.
So couldn't this be a sarcoid? I'm just thinking
Exactly.
it's
So
flooded
we
with
are also thinking of that.
granulomas.
Yeah.
It's just
Granulomas,
flooded,
sir,
but I've never
airspace.
seen sarcoid presenting acutely
So the
like this.
lymph node
Yeah.
sampling I didn't do because I had to choose one stop test which is cost effective for the patient. So otherwise I would have done lymph node biopsy through EBUS. We were there, but patient had cost constraints, so we picked up one test where we could hit hard. So lung biopsy would give better answers. So I didn't touch the EBUS at all.
The airspace granulomas are there in this patient. So sarcoid, we don't find airspace granulomas. They are mostly lymphangitic distribution, and those granulomas are very well defined, and they have this onion skin fibrosis. But these granulomas here are typically they are looking like infectious granulomas. These are not hypersensitivity pneumonitis also because again, I mean the airspace granulomas.
I think Professor Athol Wells wants to talk.
Yes,
I think we should allow him.
So coming at this, we may as well tick off the things it isn't, because we haven't discussed, I think, a key diagnosis this could be. So you've got renal signal as well as signal, and you've got it on multiple imaging. So there's a multi-system pattern with this. It obviously isn't traditional organizing pneumonia. We can stop talking about that, especially with the biopsy, but it would not respond to steroid. And I have to say the same about sarcoid granulomas. like this, very weird not to respond to steroid. We've taken out malignancy, and I buy into the fact that probably his occupational exposure is irrelevant. I think there are two possibilities, and I bow to your suggestions on infection, but the word vasculitis hasn't been mentioned. You've got renal and lung involvement, you've got low-grade eosinophilia, you've got granulomas, and there are an array of vasculitic presentations where there's a prominent granulomatous component to this. You've got renal and lung involvement. I'm not making a case, by the way, for this being the first choice diagnosis, but if I'm going to say that I think infection is probably driving that, the way I would mess up this case is failure to think about a vasculitis. And so I'm interested whether there's proteinuria, whether there are red cell casts in the urine, what's going on with the kidneys. And the problem with saying it's not vasculitis on biopsy is that you have to go through large surgical biopsies sometimes with pulmonary vasculitis to find this or that feature that nails it. And we know that, for example, and I'm not saying this is EGPA, but it could be some sort of overlap variant close to it, and they're often in their lung dominant, they're anchor negative. So I would not rule out of vasculitis driving this, but on common sense grounds, infection is probably the most likely. But why would he get an infection like this at his age out of the blue?
His urine routine was negative for blood or protein. C-Anka, P-Anka was negative. We have done that. And he had no other systemic features, no skin rash, no nasal symptoms in the past.
No, I think it's difficult when you've got lung dominant vasculitis with consolidation. We had a spectrum of these, and it's amazing how often eventually they turn out to be a form of GPA downstream. But look, I'm not saying it's first choice. I am saying that we should be talking about it.
So histologically, for these GPAs and vasculitis, necrotizing granulomas is what we see, along with necrotizing vasculitis and capillaritis. But here, the granulomas are non-necrotizing.
Look, what I learned is that vasculitides don't read medical textbooks, so we polls that are classic.
Yeah, that's so true every time.
Because you don't have this histologic feature. But the trouble is, I think about a quarter of vasculitides are not classifiable, actually. And we do our best to have these clusters of things, and it's a bit like old-style rheumatologists. If you don't meet 6 criteria, you haven't got rheumatoid or you haven't got scleroderma. But actually, in reality, there are an awful lot of vasculitis presentations that lie between classical entities. So my worry here is an atypical vasculitis, and you're quite right. You can say histologically it might be atypical, but is that the same as saying it can't be a vasculitis?
Any features of IgG4?
No, there are no.
Yeah, somebody asked.
And there are no features of IgG4.
And Nishant, you got an MPO PR3 autoantibody.
Yes, both are negative.
Both are negative.
Yeah. My other question is, see, he has got cavitary lesion with intracavitary lesion in the right lower lobe, middle breast segment. So one end we are saying, and he also grew in the ball from middle lobe, aspergillus fumigatus. So we are treating for that. Now, if you talk in terms of vasculitis, we need to think about adding a steroid. So how well you all are convinced that we should add steroids now? Because what's the outcome? That's what I want to discuss now. I've not added that till now. Yeah.
I just want to add a few things actually from my experience in Sri Lanka. Actually, we see similar presentation in pulmonary mucormycosis. I mean, where they have, I think, in the CT scan there are some reverse halo signs, and also that in the in the later CT scan we can see cavity formation with some necrotic areas. So we see quite a lot of pulmonary mucormycosis. I'm not sure about the prevalence of that in India. But definitely this I'm thinking as a differential, because it's very difficult to kind of come to a conclusion mycologically, because it is difficult to kind of grow in a culture. And sometimes you say in biopsies, in the staining and all, but this radiological appearance and everything, and they usually associate with the Aspergillus co-infection as well. So I would rather be very cautious of introducing steroids into this patient, and I'll basically do a follow-up, and I might do a rebronchoscopy and then take some samples for staining and cultures. But I have a strong suspicion going to my experience from Sri Lanka.
I
Yeah, the
would
points.
rather vote for histoplasmosis because there was a
Yeah.
renal involvement also. So I had seen few cases which will mimic like a almost malignancy in PET-CT and all, and then finally it turned out to be histoplasmosis. So Vimal Raj sir, does renal
Histoplasma-
involvement explain histo?
On
Definitely.
biopsy, actually necrosis will be there for histoplasmosis. I couldn't find necrosis. I mean, a lot of necrosis will be there for histoplasma, and again, GMS stain is negative. So on biopsy,
Well, he's not diabetic. He is not diabetic patient. He was very fit and active. So thinking about mucormycosis in a non-diabetic young patient,
Yeah,
bit
unlikely.
unlikely. I would not. And mucormycosis will be not just sitting like this for 4 months.
Yeah.
You would have
They will
succumbed.
worsen. They will
They
worsen.
will worsen very fast. So unlikely to be mucormycosis.
Unlikely.
Just ask, were the biopsies cultured or were the cultures just done on BAL fluid?
Yes, it's sent. Everything was initially negative.
Were the biopsies cultured?
Yes.
Quite often people do BAL for culture, histology on biopsies, but they don't culture the biopsy.
No, I've sent one full cry tissue for cultures for bacterial gram stain culture, AAB smear, AAB culture, and fungal.
I really like the suggestion of a weird infection. It's top of my list as well. And there's actually a number of organisms that are very difficult to get unless you culture the biopsies, and it takes time sometimes to do it. I mean, even nocardia, you probably have to culture tissue rather than culturing fluid. So if that's top of the list. And one thing I would say, whether we're talking histology or clinical, it's very easy to take every possibility and say we're excluding that because it isn't classical. Whatever this is, isn't classical. The unusual argument doesn't work here.
Yes.
Because whatever the diagnosis is, there are atypical features with this.
Agreed.
So I'm worried about going and saying definitively it's not condition A or condition B because of the histology. Because this is a case which doesn't fit neatly into a classical presentation.
And I'm one of the only professions.
Okay. But
The,
histoplasma antigen is there, no? Nishant, that is we used to make histoplasma antigen study and.
Yeah, I've not sent it because when I saw the city, I thought it's lapidic pattern adenocarcinoma. That's my first diagnosis.
Yeah,
So
I
with that
also.
intent, I went in. But after this, all this confusion, I just came in the enmity now because I never thought of that it'll go this long.
The differential enhancement which I showed you is very highly specific for fungal infection.
Yeah.
Which
Yeah.
fungal infection is very different,
So
but that
right
is
now I'm
very
giving
specific.
voriconazole. That's, I think, the best way to move forward. Do all of you agree with
Yeah,
that? Because-
histoplasma is treatment of choice, even fluconazole. So I think it should work.
But right now we have grown aspergillus, so we are treating that. I think it's fair, right? There's nothing else
Yep.
to be done at present. So we'll wait and treat. That's it, and
Wait
we'll
and
follow
treat,
it up.
wait and treat, wait and treat.
Thank you. No steroids. Agreed.
Yeah. Okay, so Mulliman sir is joined from somewhere, but he's. So last two cases. Okay, sorry, not this case. I will put the other case. So Vimal Raj sir should not have problem. Yeah. Yes, madam.
Good evening. 49-year-old female. She works as a KSFE bill collector. She goes around collecting money from shops and other places for financial enterprises. Her presenting complaints were shortness of breath since 4 months, initially grade 2, which has progressed to grade 3 in the last 1 month, and non-productive cough since 2 months.
1 second. Yeah.
She has a past history of ulcerative colitis. The colonoscopy last year had shown pancolitis, and she was on mesalamine for the last 1 year. She is still on that medicine. She has also history of palmar psoriasis. And when I asked her about exposure, she said 2 pigeons sitting in the close neighbor's chimney since 1 year, and it is very close to her room. That's the only thing I could get from her. And there is no family history of any lung problems. And examination was perfectly normal. Right. And she was actually initially worked up well in Aster Hospital in Kannur in October 25, where she underwent CTD and HP workup also was done. And she also underwent transbronchial cryobiopsy of the right lower lobe. Unfortunately, because it is from another hospital, I could not get the histopathology slide. Mild focal septal non-specific chronic inflammation and fibrosis. No evidence of granuloma was the result. And yeah, this was the results from the previous hospital. All her CTD workup, including anti-MPO, anti-PR3, were all negative. HP panel, the common HP panel, was also negative. And this was her X-ray on presentation on the 8th of December, which showed, I think, Vimal sir, can you just go on to the CT?
Yeah, certainly. So this is CT of the 49-year-old female. The one thing in the mediastinum is that the main pulmonary artery is slightly prominent. It's around 3.1 centimeter. There are not many lymph nodes, and axilla and everything is clear. And we look at the lung parenchyma as such. What we are seeing here, I'll just bring this up a little brighter here. You're seeing this diffuse bronchocentric ground glass changes in the lungs bilaterally, both upper and lower lobe involvement, with mild areas of sparing intermittently. Some of these are tiny nodules, but otherwise there are no specific isolated nodules. There's no cystic changes. There is no traction dilatation of bronchi. There is no honeycombing. When we compare the inspiratory and expiratory scans together, what you're seeing, the right one is the expiratory scan. Mild accentuation of the mosaicism that we had seen before, with some small airway component associated with this. So this is bronchocentric interstitial pattern of ground glass change with some airway component. So differential diagnosis remains within a HP and a CTD. Some of the clustering of these nodules, which you may be able to see on this image, kind of points more towards CTD, but those two are the differential diagnosis I would be considering, CTD versus HP.
Which CTD, sir?
This looks like a multi-systemic CTD, multi-connected, because I'm not seeing any dermatositis pattern in there. The myositis pattern is not there. It's very diffuse in involvement, so nothing that I can point out to. And with the PA being enlarged, don't know if there is any pH or not. It's not very specific for scleroderma Sjogren's either.
But you can see this in ulcerative colitis, no? Vimal?
Yeah.
An inflammatory bowel disease. She has a small airway disease component. And I was just thinking there's so much autoimmune palmar psoriasis. It's a very strong autoimmune signal.
Yeah.
What one would classify this as is difficult. What's the question, Sobha?
Yeah, I'll just share.
Yeah. Yes.
I'm also interested in mesalazine.
Oh, yeah. Oh, mesalazine.
Yeah, that's true.
Because you can get very diffuse abnormalities on CT with ground glass, sometimes with a peribronchial accentuation. It can look like HP. And especially if somebody's been on mesalazine for quite a long time and an infection.
It's less than 1 year.
Sorry?
Less than 1 year, the duration of treatment.
It may be coinciding with the development of this. It's like the last case. It's not the first choice diagnosis, but if this is what's driving it, it would be a bad thing to miss.
Yeah. Okay, I'll just share. Yes, ma'am.
I have the PFT, which is showing significant reduction in the FVC with the 61%. DLCO is reduced to 39%. KCO is 63 VA. So significant reduction in the lung function. So there is significant problem, as we could guess. And her 6-minute walk test was normal. There was no desaturation, and she could walk 360 meters without any breathlessness. And 2D echo, which was done in the other hospital, had shown grade 1 LV diastolic dysfunction. That's all. And I think we have discussed. Yeah. So what is the diagnosis? How should I proceed further?
You started already on steroids, ma'am?
Yes, because on questioning her again, she gave me a history of being exposed to, she goes every day for the last 6 months to a bird shop where all the kinds of birds are there, and she has to sit there for about 1 to 2 hours every day. And she used to get awful respiratory symptoms from then onwards. And this whole thing has started after she started visiting this place.
It's one of those cases with multiple candidate triggers, isn't it? You've got ulcerative colitis, she's on mesalazine, you've raised HP. The scan isn't distinguishing between these possibilities. Could be any two of the three acting together. Infection might have come along and sensitized the lungs to mesalazine, or in some way have provoked as a cofactor developing an ulcerative colitis problem in the lungs. So it seems to me the first key is to take mesalazine out of the equation.
Okay.
Stop it. Work with a gastroenterologist, sure. Decide on an alternative. But I think you've probably got to stop mesalazine, even though it's not the first choice, because if that is really contributing and you keep on going with it, there will be confusion, right? Then your management broadly, I think, can cover the other possibilities because all of them are abnormal immune responses that one hopes will respond to a fairly standard approach to immune dysregulation driving ILD. So in a way, it's not too stressful, is it, how you manage this? You avoid your major mistake, which would be to not stop mesalazine. And then you just give this some time with some therapy. But anyway, that's enough from me. What do other people think?
Prahlad? You're muted. You're muted.
Is absolutely right. I feel we should think about that first, remove that molecule from that drug, do a BAL, which may show eosinophilia also, which will support the.
It was not there. It was done already.
No, I think Athol was saying this is not mesalazine induced.
No, but it can.
I would not exclude it being mesalazine lung. I don't think you can look at this and say, I know it's not mesalazine lung.
Sure.
It's not my first choice, but that doesn't mean it can't be the right answer.
Right.
So what you're saying is, how do you avoid making a mistake in a case like this? And the mistake would be to keep going with mesalazine if it really is mesalazine lung, even though I'm favoring an alternative. I think we're in a difficult position with 3 possible triggers, and any 2 out of 3 might be playing a role. You know, for clarity of thought, we like one condition, one cause, but in reality, a lot of what we deal with is an interaction between triggers. It's more complex than that. So you've got a management that covers all 3 triggers.
How long has he been on mesalazine, Shobha?
Year.
Less than a year.
Okay.
So it has coincided with the development of this.
Yes,
but
yes,
if
yeah.
she'd been on mesalazine for 5 years, I'd still be saying you can't rule out an infection sensitizing the lungs to mesalazine. It would make it less likely, I agree, but the fact she's been on it for less than a year means that I think you do have to take it out of the equation.
Yeah, because his symptoms are since 4 months, Shobha,
Yes.
and 1 year on misalazine. I mean, the time points are pretty much could match it. Yeah.
Maybe we have to continue steroids for uh, time being, na, sir? That she
Look,
has already started.
I have already started. Yeah.
if I'm honest about this, I think maybe there's a 20% chance that misalazine is playing a major role. But if it is, and you don't stop it, then
Yes, I will definitely
Yeah.
do it. Yeah.
Stop visiting to the bird.
Yeah, her cough has come down after she stopped visiting.
As Shobha said, there are two birds. You should stop visiting both the birds.
That was very practical suggestion. Okay, we'll move on to the last case. Even though we have four, we are really running short of time. Yeah. Yeah. Over to you, ma'am.
Yeah, this is a 49-year-old male patient who is an electrician, no comorbidities, and he underwent routine health checkup for getting a visa for Qatar. Chest X-ray showed some abnormality, so he was advised CT scan. At that time, he was asymptomatic. That CT is not available with me. Numerous centrilobular, subpleural, fissural nodules were there in bilateral lung fields. Multiple calcified and non-calcified, discrete and conglomerate mediasternal bilateral hilar nodes were there, and numerous para-aortic, subdiaphragmatic, perigastric, peripancreatic lymph nodes were also seen in that. So 6 months later, he presented to us with cough, 20 days duration, associated with scanty mucoid expectoration. He took antibiotic course for 4 days. He had dyspnea on exertion, fever 20 days ago for 4 days, no hemoptysis, no chest pain, loss of weight, orthopnea or PND. And there is no history of pulmonary tuberculosis, vaccinated for COVID. And this was his presentation chest X-ray in March 2024. So we don't have a corresponding CT. With this X-ray finding and CT reports and CT scan from...
We will show that CT scan?
We don't have that CT. It is not there.
Okay. Okay.
Right.
1 second. Yeah.
Yeah. Bilateral hilar retinopathy and underwent linear EBUS, and TBNA was taken from 10-hour, 4-hour, and a mucosal biopsy, cryobiopsy was taken from the left lower lobe mucosa. And yes, the TBNA from the lymph nodes did not reveal any particular pathology, but the cryobiopsy from the mucosa showed granulomatous inflammation, non-necrotic granulomatous inflammation. Then EBUS TBNA showed scanty lymphocytes from all the stations. So we had a discussion, and we made a diagnosis of sarcoid stage 2, endobronchial biopsy suggestive granuloma, mediastinal lymph node, no granuloma. Needle wash was negative for AFB, gene expert was negative, Manto negative. ACE levels was 92 on initial evaluation. All his biochemistry, calcium, renal, LFT, ECG, they were all normal. And this was the TB culture result from the needle wash, which was also negative. Anyway, he was started on oral steroids, and he was given a course over 10 months, but in between he went back to Gulf, started working there, and then he landed up on 21/5/2025. That was about 4 months after stopping his steroids. And this was the HRCT taken at that time, 4 months after stopping steroids.
So this is a 51-year-old gentleman, and what we can see is that there is still extensive persistent mediastinal lymphadenopathy. You can see some areas of soft calcification which has come into these lymph nodes, bilateral hilar lymphadenopathy, and the lymph nodes are there along the anterior diaphragm, retrocrural space. The lymph nodes are still there in the upper abdomen along the retroperitoneal aortic space also. So lots of lymph nodes persist. And we look at the lung parenchyma. There are some peripheral areas of nodularity that we can see in the pleural bilateral lungs. You can see along here. Again, patchy focal areas of peribronchial nodularities, not that distinct, but then lower down in the right lower lobe, we are able to see these focal area of consolidation with some peribronchial nodules here, as well as some subpleural nodules. All these are predominantly peripheral nodules. One or two fissural nodules, minor areas of fissural bleeding. Otherwise, the lungs were clear. So, in summary, we've still got extensive mediastinal and hilar lymphadenopathy with upper abdominal involvement, and there are these distinct nodules in the lungs and right lower lobe consolidation, all still fitting with pulmonary sarcoid appearances.
We'll give the last word to Athol on this. So
Yeah.
Prahlad and I will start.
Then he
First
he
question.
went back to Gulf, and 6 months later he's coming back. He doesn't have any symptoms, clinical, radiological stability, but his ACE level is kind of going up, 129, 120. It was 92 at the time of diagnosis. Then it had come down to 58. And his lung function is normal. He is asymptomatic. Should I treat him? Should I not?
So Shobha, one could do a teaching class on sarcoid on this, and Athol, the Wells law will really. So I can tell you the staging system. So Shobha, we use less and less often in the last few years. So I'm not sure. Do you all still use that, Shobha? Because we don't use it in clinical practice, and we also actually are really looking at how bad the symptoms are before we treat. This is most certainly looking like sarcoid. Also, what the steroids were given. We have the Predmet trial published last year.
Yeah. This was before Predmet trial.
This was before the Predmet trial, but
yes.
I'm just wondering whether I would have treated at that time. I know he had symptoms, but we don't have a lung function at that time. We just have an X-ray and a scan, right?
And he had normal lung function.
Correct.
Yeah.
So that's
normal lung function, still normal lung function.
It's tricky. And then I'd give it to Prahlad what he would do, because I've had my debates with
I think
Prahlad on
she has
such patients, and
achieved
we'll give
to
the
send
final
him.
word to Athol.
I think the X-ray chase itself says no investigations are required. Okay.
Yeah,
That's
classical
one.
X-ray.
Second, it's a sarcoid. Second thing is that she might have achieved that at least he could go to Gulf because they want only X-ray clear. Okay. So for that point of view, if they are given steroids, then probably patient must be very happy.
Okay, I would have done everything I could to avoid treating this patient. To 2005, where I first developed the twin indications for therapy, danger and unacceptable loss of quality of life, and do not touch a patient with sarcoid unless they tick one of those two boxes. I'm not too doubtful about the diagnosis. It does seem to be fairly rock solid. You probably have to say sarcoid is never 100% likely. in any scenario, you probably have to say, I have to follow this patient and just take note of anything atypical. And with that background, I'd say an established diagnosis, not a working diagnosis on what you have. So this is sarcoid. I just think we've poisoned patients for decades. Some of you will have seen an urgent statement issued by WASOG about 3 months ago, which is a declaration of war on steroid therapy. It's still appropriate with dangerous disease if you need a quick response, and then you should be working towards minimizing duration of steroid to at most 9 months and going quickly to alternative agents. This was all worked out with very careful observational studies, and PredMef was good because all PredMef did was to say, yep, the observational studies were 100% right. So PredMef delivered exactly what you would have predicted. And that's a compliment to Bob Buffman and one or two other older clinicians who just worked out gradually what worked in sarcoid. They didn't make eminence-based statements. That happened in IPF where people jumped up and down and talked about high-dose steroids, and that was not based on humility and working things out. But avoiding steroids at all costs if you can. Some patients require you to deal with their symptoms immediately or they won't take therapy, so you're forced to give steroid for bad symptoms occasionally. But you tend to introduce a second-line agent at the same time. In this case, I would do everything I could not to treat the patient, and I do wonder whether that cough was all about a viral infection coming along with a bit of post-infective bronchial hyperreactivity rather than a sarcoid manifestation per se. That was when he did get some cough from what you said. So leaving this patient alone, monitoring them, and I would have been saying that for the last 23 years, I think.
Oh my God.
Yeah, so I've been saying it for the last 8 years, much less than Athol.
Since the time you met Ethel Wells.
I'm younger than I am, Sue.
Yeah. Can I ask one doubt about PredMed
But
trial, sir?
Athol, just before Asmita's question,
Yeah.
Athol, would you advise Asmita and Shobha's postgraduates not to use the staging system anymore, or should we still use it?
The student tells us very little. And in fact, we're just developing and about to submit a lung function staging system, which simple lung function, which leads to getting completely useless. People have obsessed with stage 4. And I think the problem is that the patients that get onto transplant lists have got stage 4 disease, but there's an awful lot of other stage 4 patients that have a little bit of fibrosis, but you can see this fibrosis on a chest X-ray. We've just done a CT study, and the prevalence of fibrosis and its extent are actually identical in stage 3 and stage 4. And even in stage 2, there's not infrequently a fibrotic element there. So I think the problem is that system is fine for large cohorts. For large cohorts, you will see differences. Stage 4 in large cohorts gives you a mortality increase of maybe 5%, maybe 10%. It's useless in individual patients. There's observer variability in what you cause stage 4. These days, a CT radiologist will come along to a chest X-ray and claim they can see fibrosis because of their CT skills. And we did a study showing significant observer variability in even calling stage 4 in sarcoid. So I think far too much is made of it. What really matters for outcomes is lung function.
No.
That's useful. Very
Yes,
good.
I wanted to ask, sir. So we we have staging system for the thoracic lymph node, and that is why it is so confusing that when we are seeing the lymph nodes in other parts of the body, does it apply to that also? Because in this particular patient, every lymph node was enlarged. So that is why the confusion. So we also agree that we don't want to treat stage 1, stage 2 and all, but if there are lymph nodes in the abdomen or any other parts, or even supraclavicular lymph node.
Nobody has shown that treating lymph node inflammation achieves anything other than steroid side effects. Now, in a blue moon, you get a huge lymph node that is compressing a large vessel, for example. Occasionally you'll get a local problem due to a very large lymph node. We absolutely don't treat lymph node inflammation otherwise. You won't get a gain. And potentially terrible steroid side effects. A lot of patients don't seem to ever manage to get off steroids once you start them.
Yes.
I think there's a form almost of steroid addiction.
Okay.
Once people are attuned to being on steroid, the damage that's been done with steroid and sarcoid is incalculable. It's a crisis. It was very interesting when we drove our statement through WASOG, and there were 5 proactive patient group leaders. I tried not to be melodramatic because I was pushing for declaring war on steroid from the outset. So I tried to say, we've got to think of steroid as a crisis in slow motion. They actually said, stop saying that. It's a crisis. It's not a crisis in slow motion from a patient point of view. So we've got to have a good reason to use steroids. We should be thinking about methotrexate or azathioprine instead of steroid. If we are going to treat sarcoid, we should be avoiding steroid unless there's a reason to give it. And on the same careful observation, we don't yet have azathioprine versus methotrexate, but I would predict equivalent.
And the second question was, when you said that methotrexate and steroids together, you might stop steroids at 9 months. Do we need to treat? I was thinking 3 to 4 months is the when both the Kaplan curve starts getting together.
We said in our statement was ideally you're looking at getting people off steroid at 4 months. Now, to achieve that, if it's obvious you're going to need long-term treatment, what you don't do is give steroids, try steroids by themselves, and then conclude at 6 to 9 months that you need to add a second-line agent, because then that patient's stuck on steroids for too long and struggle to get them off. So what you tend to say is, unless you can be fairly sure that you will be looking at no therapy in 4 to 6 months' time, it makes sense if you must use steroid. You're driven by the patient. The patient's telling you, my symptoms are too bad, I've got to have a response in the next week. And you accept that, but then you would add methotrexate and use combination therapy. You would anticipate that methotrexate might take 3 to 4 months to reach its effect. You would be down titrating the steroid as the methotrexate took effect. Why delay? Because if once you've signed up to, you're going to use second-line agents if you need to get people off steroid, and it's obvious to you that you're not going to get away with 6 months of treatment and stopping treatment, why just wait and prolong the time on steroid rather than using methotrexate or azathioprine from the outset? And then if the patient doesn't want steroids, and as you know, a lot of people have steroid phobias, thank goodness they do, because they give us an alibi for not using steroids, then you really strongly support methotrexate or azathioprine monotherapy from the outset. And then the other thing in more dangerous disease, like cardiac sarcoid, unless you can establish fairly quickly, and you'll use steroid to start with, but you'll want people off steroid and just on methotrexate, and you establish quite quickly that that's not feasible at 4 to 6 months with a repeat PET, and then you introduce anti-TNF at that point. You don't mess around trying to find a long-term low dose of steroid plus methotrexate. And that also is recommended in that statement.
One question I have. A few of our patients have mentioned severe fatigue, which is actually not mentioned in any of the guidelines as a red herring symptoms. And a lot of them come back saying, I'm really, and we don't want to give steroids. I say, I'll not treat you, wait. Then they go and get second opinion, third opinion. Patient still comes back saying severe fatigue. How do you treat that? How do you manage
Well,
that?
we did set it out in the BTS statement. And I think you're quite right. I still do. I see a new patient and I ask them, if you could get rid of one thing, what would it be? And 2/3 of the time it's fatigue. You do have to actually go to some length to explain that fatigue is genuine because people with fatigue look well and they often have the message from their family or their local doctor that this is all in their head. And it isn't. It's disabling. So fatigue generally won't respond to sarcoid therapy. A few patients early on do. I will give you that. But once fatigue has set in, it's terribly rare to get a decent response to any of our traditional sarcoid therapies. And in fact, people go on using them, and actually, some of the drugs cause fatigue. I mean, methotrexate, the number one side effect is fatigue. So you get yourself into this bind, and you have to do a series of other things. First of all, you actually talk about triggers of fatigue. You ask the patient to identify which people around them are energy drainers. Some people you deal with are energy drainers, commonly mothers-in-law, actually, but energy drainers, and which tasks drain your energy. You try to give the patient a way to control the fatigue. Now, even if they only get a 30% control, it's hugely important to people that they're helping to take control. Graded exercise works for some people, and so you use a rehab approach. But you need to know that for some people, exercise worsens fatigue. So people are messianic about exercise. They go on and on and on about exercise. Apparently, it's the cure-all, but it isn't always. So it can be invaluable in sarcoid fatigue. Ginkgo is hugely worth trying. And good witnesses, by that patients, I mean, you would trust implicitly. A number of them note benefits from ginkgo. I can't prescribe it. They have to go to a health food shop. A lot of patients really like that, that this is non-medicine with a doctor advocating it. And we've actually covered that in our statement. And so you work through these things. You exclude depression. Often people are unhappy because they've got sarcoid and it drains their energy. I always make the point that the abnormal human reaction is to be ecstatically happy about having sarcoid. So we're not talking about a psychiatric disease, but depression is a big deal, and so is sleep disturbance. If you've got arthralgia or you've put on weight because of steroid, you will be fatigued from sleep apnea. And finally, Ritalin. And Ritalin has controlled trial data in sarcoid, establishing a clear benefit in fatigue. So an attention deficit syndrome drug, is it methylphenidate? There are two of these drugs with trial data. I think it's methylphenidate that is Ritalin.
Methylphenidate.
That's right. And I don't like to do that till I've done the other things. And when I talk to patients, they don't want me to advocate that till they've tried the other things. So you've got a real algorithm you should use for fatigue. And at the end of it all, patients, I think they give me the message that they get huge pluses from going through this approach with fatigue, because generally nobody's done it. Generally, it's been put under the counter because people can't handle fatigue, so it tends to get dismissed as it's all in your head. So if you really want grateful sarcoid patients, get them to talk about fatigue and take them through this algorithm.
Thank you.
Okay. I think that's it.
Our palliative care physicians often say, just listen to the fatigue for some time.
No, I think it's a good line. I'm going to use
Whether we should listen or they should listen, sir. Yeah. I think that's it. We have 4 very, very difficult cases. 2 of them we didn't reach diagnosis yet. But rest of the two, I think third case, we still have to find out what happens after stopping mesalazine. The fourth case is clear cut that don't give anything if he has stopped. And thank you so much. The next meeting will be on, I believe, on 23rd of January. Thank you, Vimal Raj sir. Thank you,
Thank you.
Professor Wells, Prabhu
Thank
Desai sir, Rajan sir. Yes.
Very good. So great.
And a happy new year to everyone.
Happy New Year to everybody. Yeah. Thank you,
Nice.
Nishant, for coming
you.
over and presenting. Thank you, Lisha, for joining. And maybe we'll get some answers by getting lymphoma panel antibodies over after all. Okay, sir.
Bye-bye.
Bye-bye.
Okay, bye.